Okay, we are at 11 o'clock. So I think we can go ahead and get started. If people trickle in after we start the meeting will be recorded and it will be sent out to anybody who did sign up for the webinar. So thank you all for joining us for this very important conversation on supporting maternal mental health in Brown County. Mental health conditions are the leading cause of maternal mortality in Wisconsin, yet they often go unrecognized and untreated. One in 5 individuals will experience perinatal mood or anxiety symptoms, but 75% never receive the care they need. Today is an opportunity to learn together, strengthen our partnerships, and think about how we can better support families during pregnancy and postpartum. Next slide. So a little bit about us. So Brown County Public Health has been awarded funding from the Wisconsin Department of Health Services, Title V, and the American Rescue Plan Act to support perinatal mental health in our community. We are working to increase awareness, education, and support around perinatal mental health through collaboration and community engagement. Today's presentation with Periscope Project is one example of how we are bringing education and conversation to our community. We are also conducting both community and provider surveys to better understand current gaps, barriers to care, and resources families and professionals need. In addition, we use community events and social media outreach to help increase awareness, share resources, and encourage families to seek support during pregnancy and postpartum. Next slide. So here at Brown County Public Health, we want to support maternal mental health in our community, but we cannot do it without our community. So our community's experiences during pregnancy and early motherhood will help us understand how moms in Brown County are doing and guide the creation of resources and solutions that may make a more impactful difference. So I will put a link after I'm done talking to the survey in the chat. So this is the maternal or motherhood wellness survey that we are conducting, and it will be open until July 31st at midnight. Next slide. We are also collecting information from healthcare providers and community partners to better understand perinatal mental health screening, referral practices, and system capacity in Brown County. The goal of this survey is to help identify existing supports, understand where gaps exist, and learn about the challenges providers and community partners face when supporting pregnant and postpartum individuals. So this survey will be available until June 30th at midnight, and I will also post a link to this in the chat. And then next slide. So just a little introduction on the Periscope Project. So the Periscope Project is a project of the Medical College of Wisconsin, Department of Psychiatry and Behavioral Medicine. It was created in 2017 to address gaps in perinatal mental health care options in Wisconsin. The Periscope Project is a perinatal psychiatric access program building capacity in frontline health care professionals by offering 3 core services, including consultation, education, and resources at no cost to utilizing healthcare providers or the patients they care for. And I'll also put a link to their website in the chat as well. And finally, we're excited to welcome our presenter, Dr. Christina Wickman with the Periscope Project. Dr. Christina Wickman is a professor of psychiatry and obstetrics and gynecology at the Medical College of Wisconsin. She completed residency in adult psychiatry and fellowship in consultation liaison psychiatry at Mayo Clinic. Clinically, she created and directs a co-located perinatal psychiatric services and is the co-director of women's mental health at MCW. She is the medical director of the Periscope Project, a provider to perinatal psychiatrists teleconsultation service. Dr. Wickman has published and lectured extensively, regionally and nationally. So at the end of Dr. Wickman's presentation, I'll put up a quick evaluation in the chart or in the chat for the webinar. We are grateful to have Dr. Wickman here to share her knowledge and help guide this conversation. So I will pass it on over to Dr. Wickman. Thank you.
Thank you so much, Becky, for your kind introduction. Good morning, everybody. I'm going to utilize hopefully the next 45 minutes or so to do a very broad overview about perinatal mood and anxiety disorders. I had shared with Becky earlier, I may not have great access to the chat, so if there are questions, please don't hesitate to come off mute, interrupt me along the ways. We certainly should have some time for questions at the end as well. So just making sure that we're all on the same page definitionally. So when I talk perinatal mental health conditions, what I'm referring to are all mental health conditions that occur during pregnancy and up to 1 year after delivery. So that can include mood disorders, anxiety disorders, bipolar disorder, substance use disorders as well. So really that entire caveat. And then again, the term perinatal, pregnancy, and up to 1 year postpartum. As Becky had shared with her introduction, unfortunately, we know that maternal mental health disorders are the most common complication of pregnancy. A lot of our obstetrical providers may learn about gestational diabetes or high blood pressure, preeclampsia, but 1 in 5 individuals will experience a mental health condition during their pregnancy or in that 1 year postpartum. And for a lot of different reasons, women oftentimes go untreated or undertreated. And because we're dealing with maternal mental health, it's not just in fact impacting that individual, but that mother-infant dyad and really that entire family. Also, as Becky had mentioned, maternal or mental health conditions are the leading and most preventable cause of pregnancy death. I have the honor of sitting on Wisconsin's Maternal Mortality Review Committee, and we look at every case of a woman who has died in our state, either during her pregnancy or up to 1 year postpartum. And what we're seeing is that highest percentage are secondary to mental health conditions, primarily suicide or overdose. What we also know is that when women are at highest risk is actually several months post-delivery, when they may no longer be engaged in regular obstetrical care or care with a family practice or primary care provider. So when they fall off the radar, unfortunately, that is when their risk increases. So it really does behoove us to continue to screen for mental health and substance use disorders, not just during pregnancy, but in that full first year postpartum. We also should be engaging our pediatricians and our family practice docs that are taking care of that whole family. We've got some great evidence to demonstrate that screening for maternal mental health disorders at the pediatrician visit or the child visits can be incredibly powerful as well. We know that there's a lot of factors that are associated with an increased risk of a mother having a higher risk of having a maternal mental health disorder. Some of these make a lot of sense, right? If there's marital disorder, lack of social support, they're living alone, there's an unwanted pregnancy. Our teenagers at younger age, that risk goes up to 1 in 4 versus 1 in 5. Women who have very close pregnancy intervals also have a very high rate of developing a maternal mental health disorder. And lastly, we know that women who have had a mental health disorder and are actively getting treatment for it, if they were to discontinue their medications at time of conception, their risk of relapse is incredibly high. This study demonstrated nearly 70% at some point during their pregnancy or first year postpartum. Common things being common, the most common things that we deal with are depression and anxiety. And so that's kind of what we'll focus most of this talk on. I do want to differentiate, however, between baby blues and depression. So baby blues is a normal condition that occurs within the first 2 weeks post-delivery. So we expect that the vast majority of women will have what I lovingly call a hot mess mama phase, right? It is hard. It is a hard couple of weeks to adjust to motherhood. They may experience mood swings in that immediate postpartum period. They may be more tearful, more anxious, have difficulty sleeping. That being said, that is self-limited, doesn't require a lot of intervention, certainly not pharmacologic or medication intervention, and resolves really on its own with some education and support, typically by weeks 2 to 3. What is different from that is postpartum depression. So postpartum depression is either that baby blues never resolves and it continues to persist, or they resolve from baby blues and then develop a depressive disorder sometime later in the postpartum period. Women who are struggling with depression definitionally need to have symptoms impacting nearly every day for greater than 2 weeks. So when I get a phone call about a woman who's struggling with depression and she's only 6 days postpartum and she had no issues prior to delivery, that's not a depressive disorder, just by definition alone and timing of it. Postpartum depression impacts, again, I don't know, about 20% of women or so. And again, that highest risk is that throughout pregnancy and up to 1 year postpartum. In the last decade or so, I think we've done a much better job of screening for depression. We are catching up for screening for anxiety, but we know that they can be two distinct disorders. So if we're only going to be screening for depression or asking questions about depression, we may miss women with pure anxiety disorders. So generalized anxiety disorder, obsessive compulsive disorder, or panic disorder, PTSD. The prevalence is very similar to women with depression. So again, while they may overlap, it could be a very distinct disorder that we do need to be mindful of as well. And so that's where we can kind of come into screening to help identify women who may be struggling, because obviously women may not just tell us up front if they're struggling, and we certainly can't tell by just looking at them alone. So we should be asking all women about mental health symptoms as well as substance use. There's lots of different guidelines out there nationally, but about how frequently we should be screening. But this is one screening guideline. So if we're utilizing the obstetrical visits as timing to help with screening during pregnancy and postpartum, we recommend screening at that initial prenatal visit, whenever that may happen. So if that's early, first trimester, 6 to 8 weeks, great. If they present late to prenatal care, that's actually a red flag for a mental health condition. So we should absolutely be screening them at that point. Given how long pregnancy is, we should be screening again at about the 28-week visit. If they're doing that in conjunction with their obstetrical visit, that oftentimes aligns with their gestational diabetes screen. So they have to be in the office for about an hour or so anyhow. So we hand them a screening tool at that point. I talked about that hot mess mama, baby blues. You'll see that I don't recommend screening at time of delivery because they're in pain. They are sleep deprived. There's a lot going on hormonally. It's not a great time to screen women immediately post-delivery, nor in those first 2 weeks, because we anticipate that we'll likely have some false positives with screening because of baby blues. So we recommend screening at 2 to 4 weeks postpartum, or again, using our obstetrical visits at that standard 6-week postpartum visit. Here in the great United States, women are returning to work usually by about 3 months, and that is another blip that we see, particularly of a lot of anxiety, and that another transition point. So that should be another point that we are maybe not engaging with OB, but maybe that is well child visits, is that primary care. Whenever that woman is interacting with the healthcare system, we should be trying to get her screened. And then again, given the risk that we see with maternal morbidity and mortality later, so that 9 to 12 months postpartum as well. There's lots of different screening tools that we can utilize. The two that are most commonly utilized in this patient population are the Edinburgh, the EPDS, which is specific to the perinatal population. So it does eliminate a lot of the somatic or physical complaints of depression that may be different because of pregnancy. So it's not going to ask about changes in appetite or changes in sleep or energy, because we know that those may be different in pregnancy. The other most commonly utilized one, certainly in our primary care population, is the PHQ-9. Both of them are validated for the perinatal population and can be utilized. Whatever works best into workflow or what you have access to is completely fine. The one nice thing about the Edinburgh, however, is that it has a sub-screening tool for anxiety embedded within it. So questions 3, 4, and 5 can be a standalone anxiety tool. So if you only want to utilize one tool for the perinatal population, the Edinburgh would be the one to utilize. Whereas the PHQ-9 does not ask any questions about anxiety, and you need to then be utilizing typically the GAD-7 or the Generalized Anxiety Disorder 7 screening tool. Again, another brief self-report specifically looking for anxiety disorders. The Perinatal Anxiety Screening Scale, or the PASS, again, as the name suggests, it is specific to the perinatal population. Honestly, I don't see this being utilized a lot. The one that I see is either the standalone EPDS or the PHQ-9 and GAD-7 in combination. Let's talk a little bit more about perinatal depression and what that is looks like diagnostically. The most important thing to recognize is that regardless of when a patient has an episode of a major depressive disorder, a major depressive episode, the diagnostic criteria is the same, regardless of if it's happening in pregnancy, postpartum, or just in a general adult patient. The diagnostic criteria does not change. It needs to have at least 2 weeks of symptoms that are severe enough to impact functioning. So ability to care for herself or her baby or function at work or at home. Diagnostically, patients need to have at least one symptom of either depressed mood or anhedonia, that loss of interest or pleasure, and then 5 or more of the criteria listed in the green, kind of our secondary criteria. What we know, however, is that depression in pregnancy tends to be overlooked because of so many of those somatic symptoms that I had mentioned before. You know, we kind of poo-poo that. Of course, you're not sleeping well. Of course, you're not tired all the time. Of course, you don't have, any interest in sex or activities that you used to do. You're growing a human. And we just kind of minimize all of those things. What we should be thinking about is what I call our emotional symptoms to help guide our diagnosis. So again, depressed mood, anhedonia, feelings of guilt, passive death wish, anxiety symptoms, certainly any thoughts about suicide. But we need to be mindful that women who are depressed in pregnancy are oftentimes overlooked because of the overlap with those somatic symptoms. And where that overlap often can also be seen is this vicious cycle with depression, anxiety, and physical symptoms. So what I mean by that is that a woman who's struggling with depression is more likely to be complaining about nausea, about GI symptoms, shortness of breath, back pain. If you're working in a clinical setting, these are the patients who may be calling the nurse 2, 3, 4 times a week, complaining of a new physical symptom. And so that should be a red flag for us to be checking for depression or anxiety. And then the flip side is also true. If we've got a woman who's struggling with, say, hyperemesis or sciatica or severe back pain, she's more likely also to be struggling with depression and anxiety. And so tackling both of those at different points can be really helpful, not just focusing on her physical symptoms, but screening and treating her for a mental health condition is going to be most beneficial. What other red flags should we be looking for that may not be, highlighted on a screening tool? I think about these particularly, say, for the folks that may be going into the patient's homes, or if you have kind of a little bit of insight, so either home visiting or virtual visits, asking some questions that aren't well captured on screening tools. We'd expect sleep to be disrupted, even, in late pregnancy or certainly early postpartum. Of course, they're not going to be sleeping. They're growing a baby or they're caring for a baby. The key then isn't how are you sleeping? The key is, are you able to sleep when the baby is sleeping? So if that baby is asleep in the bassinet after being fed and diapered, and that mama is not sleeping, that's a red flag. That's something that we should think about. Is she back below her pre-pregnancy weight by 6 weeks postpartum? If she's gained 20, 30 pounds, and all of a sudden she's back below pre-pregnancy weight. Is it because she's not eating? Is she anxious? What's going on that she's lost all this weight so quickly? Is there any loss of interest in self-care? I ask, when's the last time you showered? I oftentimes tell my patients, sunshine, exercise, and taking a shower every day is going to make you feel way better than any antidepressant I can give you, right? So that's important to kind of be grounded in those self-care pieces. Certainly, if there's any evidence that the infant's not being well cared for, social isolation, again, thoughts of harming themselves or others are all things that we should have pretty big red flags for and asking some more questions. Most of our screening tools will ask about suicide. That it is not uncommon for women who are struggling with depression, even in pregnancy or postpartum, to experience suicidal thoughts. But suicidal thoughts themselves does not mean that they are an imminent risk. And so that's a continuum that is really important to get more information. So if a patient is indicating on a screening form or they disclose to you that they've had thoughts of suicide, please take the time to ask more questions, because just because they're having thoughts does not mean that they have any intention or plan on acting on those thoughts. It doesn't mean that they don't need help. It just doesn't mean that we need to get them into an emergency room for an urgent or emergent evaluation. So women will oftentimes kind of disclose, if I got, so often, one of the questions I often ask will be, if you got hit by a bus today by no fault of your own, would that be okay with you? And they're like, yeah, that would be okay. Do you have any intention of stepping in front of that bus? No. So that's the difference between a passive death wish and a suicide and suicidal ideation. Okay, so being able to really understand that and tease that piece out is helpful. One thing to know is that asking patients specific questions about suicide and suicidal plans does not increase the likelihood that they're going to act on them. If nothing else, it's going to indicate that you as a healthcare provider, healthcare professional engaged with their care is supportive and willing to ask tough questions to get them the help that they need and deserve. That being said, if patients have had a history of suicide attempts, particularly high lethality, gunshots, overdoses, they can identify a current plan. And really importantly, if you ask them the question, what has prevented you from acting on these thoughts? And they can't give you an answer, that's a big red flag for me that they need urgent or emergent evaluation. Most of my patients will say, I would never do this to my child. I would never do this to my partner, my husband. My religion prevents me from doing this. I don't want to feel this way. I'm telling you this because I want to get better. When you ask them that, what's prevented you from acting on these thoughts. Those that kind of look at you blankly and they can't come up with a reason, that's a red flag. Switching gears to talk about anxiety. So again, perinatal anxiety, that's a huge spectrum of anxiety symptoms that can occur during pregnancy or throughout that postpartum period. Again, just as common as perinatal depression. We know that when there's an overlap of depression and anxiety symptoms, it usually indicates a more severe illness and with a little bit more difficulty in treating. Again, as I mentioned, this can happen at any point. Perhaps they had an underlying anxiety disorder prior to pregnancy that is now just exacerbated during pregnancy or postpartum, or it can be a new onset of an anxiety disorder at any point in this continuum as well. One thing that is oftentimes unique about this patient population is the presence of intrusive thoughts. That can happen with any anxiety disorder, but in perinatal patients, oftentimes intrusive thoughts present as harm coming to infant. So whether that's external harm or harm that mom is inflicting upon infant. The key with this, however, is that they, again, have zero intention of acting on these thoughts or harming the infant, and that these thoughts are really just stressing to them. In my nearly 20 years of practicing, I've had exactly one patient come into my office, sit down, and tell me about the intrusive thoughts that she's had about her harming her infant without me giving any prompting. And the only reason she did that is because she had been referred by a friend of hers who said, Wickman won't take your baby away. Go tell her what is going on so that she can help you and get the help that you need and deserve. Most of the time, to get women to disclose these thoughts, I give them very concrete examples. I say, women that I've treated with other anxiety disorders, they oftentimes have these really distressing thoughts that pop into their mind that are really distressing to them. I've had women tell me about walking into the kitchen with their baby and grabbing a knife and thinking about stabbing their baby, or putting their baby in the microwave and turning it on, or flinging their baby down the stairs when they're walking down the stairs. And none of them have any intention of doing these things. And it's so distressing to them to have these thoughts. They start to separate themselves from baby so that that baby doesn't trigger the thoughts. Have you ever had any thoughts like that before, is how I frame that. Inevitably, the vast majority of my mamas will say, I haven't had that thought, but I've had this thought, and this is how it has shown up with me. Okay. Incredibly useful. Now, we certainly do need to be able to assess, however, thoughts about harming baby that are intentional and are scary versus those are secondary to an anxiety disorder. In all my years of practice, women who have a pure anxiety disorder that have these intrusive thoughts of harming baby, these women do not act on these thoughts. They are terrified of these thoughts, and they will go to great lengths to avoid baby because they are so scared of these thoughts. And they have good rational insight that these thoughts are not normal. Women, however, who are psychotic, they don't have, by definition, patients with psychosis are not based in reality. They do not see anything wrong with their thoughts. They have very poor insight, and they've got these delusional beliefs, oftentimes with a religious flair behind it. These are also not patients that are coming in to a scheduled outpatient appointment because they are psychotic by definition. So they are the ones that are ending up in the emergency room or with police custody, or somebody is calling and saying something is not right with my partner, wife, sister, like something is seriously wrong here, because that is such a change from their baseline. So we do need to be able to differentiate between anxiety and postpartum psychosis, because honestly, one of the worst things that we can do is, if we've got a patient with an anxiety disorder and we take her baby away because of these thoughts, we're going to lose all rapport with that. She's not going to engage in treatment. And that's terrifying for us on the other end as well. So we do need to be mindful about that. I'm going to talk a little bit about perinatal opioid use disorders, not because they're nearly as common as depression or anxiety, but because perinatal opioid use disorders are a significant risk from a maternal mortality perspective. So we know that about 8 per 1,000 deliveries are impacted by chronic opioid use or opioid misuse, and that about a little more than half of those newborns are diagnosed with neonatal opioid withdrawal syndrome. You can see some statistics here about Wisconsin back in 2020. The data shows that maybe we are decreasing a little bit, which is reassuring. We had a very abrupt incline, and now it seems like we are plateauing in that kind of 2020 to 2022 range, and maybe coming down a little bit as well. There's this bidirectional relationship, which probably is not surprising to this group, with mental health disorders and substance use disorders. So again, a woman who has a substance use disorder more likely to also have a diagnosis of a mental health disorder. A woman who has a mental health disorder much more likely to begin to engage in substance use at some point as well. There's also a lot of overlap with the consequences of having both untreated mental health illnesses and substance use disorders. We kind of think about this as a Venn diagram here. We know that women who are struggling with mental health and substance use disorders are less likely to engage in prenatal care. They struggle to manage their own health, have poor nutrition or self-care. They're more likely to be victims of abuse and have more impaired maternal-infant bonding. And you can see that women who are struggling with mental health conditions, again, more likely to have substance use disorder, breastfeeding challenges, and those who are struggling with a substance use disorder have higher risks of overdose, death, infections, or other problems from a psychosocial system perspective. So that's just kind of with mom. And then we unfortunately also know that there's consequences to children being exposed to both untreated mental health and substance use disorders. So it's not just the impact and how mom is coping during her pregnancy and postpartum, but what does that impact look like to, again, just not just to her, but also this child and this family. Engagement with our patients who are struggling with substance use disorders, particularly in pregnancy and postpartum, is really difficult. And one of the biggest things that we struggle with is the stigma with our own healthcare system in treating these patients, and the shame that our patients oftentimes feel in having to disclose that they are continuing to utilize substances despite being pregnant or breastfeeding. So one of the biggest things that we can do to try to break down barriers is be really mindful about words. Words matter, both verbally as well as what is documented in the chart, particularly with EMRs being relatively open for patients and how they can see that they're being portrayed by healthcare professionals. And so just being really mindful about utilizing first person language, aiming for a universal positive regard, and that language certainly is time and situation dependent. So utilizing language of a person with a substance use disorder versus addict, or substance use treatment, or that they've been abstinent or non-adherent versus clean, sober, non-compliant can be really powerful as well as just an initial first step. Let's switch gears and talk a little bit about first-line mental health treatment for our patients who are struggling with mental health conditions. We have a lot of treatment options with really good evidence in the perinatal period. So certainly psychotherapy, light box therapy for our lovely long Wisconsin winters, and then people that have a seasonal component to their anxiety or depressive disorders. Again, engagement in self-care, sleep hygiene, those kinds of pieces are really powerful. There's some evidence with complementary and alternative options, and then certainly psychiatric medication management, which we've got good data with use in pregnancy and lactation as well. There's multiple different modalities of psychotherapy that have been shown to be evidence-based specifically in the perinatal population. Most commonly that we're utilizing in this patient population is cognitive behavioral therapy, which is kind of looking at thoughts, behaviors, and emotions and how those impact each other. But certainly supportive psychotherapy, interpersonal psychotherapy, and mindfulness-based cognitive therapy have also been shown to be useful in this patient population. What post-COVID has shown us is that we can be just as effective with virtual settings with psychotherapy, which I think is great from an access perspective. And a lot of these modalities can be done in group settings as well, which I think has the added benefit of bringing particularly our perinatal population together, hopefully to have some longer term supports, particularly if it can be done in an in-person setting. I mentioned light box therapy, which again, useful for patients with a seasonal component to their depressive symptoms. There's lots of boxes and devices that can just be purchased on Amazon, very frankly. A lot of them can also have some healthcare reimbursement if their insurers allow for that. The key for this from an evidence-based perspective is that the amount of lux has to be greater than 10,000 to be effective. Those less than that may feel good, but from an evidence-based perspective is not terribly helpful. The evidence base has actually shown that this is most effective if it's a minimum of 30 minutes daily within 10 minutes of awakening, so very early in the morning. So it's not good enough just to say, I'm going to look at my light box on a rainy day at noon. That's actually not been helpful. What we're trying to do is actually extend sunlight hours. So morning prior to sunshine is most effective, which is honestly why we don't need it in Wisconsin at, in the middle of June when the sun is peeking into my curtains at 5:15. It's the 7:30 in December that's most problematic. We don't recommend utilization at night because I've had patients say, well, I'll just do it at 4:30 when the sun goes down so early. it actually has been shown to be quite disruptive to sleep. So again, early morning is supposed to be helpful. I typically tell my patients to not do what this lady in the picture is doing. I tell them to actually have it when kind of off to the side. It needs to be able to hit their eyes. That's the whole point. It has to hit their retinas, but they can multitask. So if they're getting ready in the morning, putting on makeup, doing their hair, sitting down and having breakfast, whatever they're doing, or if they're sitting down to their computer and working early in the morning, to have it set up at their desk, all fine ways to be able to do that, to be able to get that exposure. Self-care, I've mentioned nutrition, exercise, avoidance of alcohol, tobacco, certainly other drugs, all things that all of us should be doing to be healthy adults, certainly again, to reinforce that in the perinatal population. Peer-to-peer support is incredibly important too. Postpartum Support International does have virtual peer-to-peer support groups, so online, and can be available. If you've got patients, depending on where you're at, Mom's Mental Health Initiative is primarily based out of the greater Milwaukee area, but they also have virtual components too. It is a very robust peer-to-peer support program. Their in-person programming is, again, all in the greater Milwaukee area, but they do allow for patients outside of that area on their online pieces too. We're looking at complementary and alternative options, those that have a solid evidence base: exercise, massage, relaxation. There's been some good evidence in the perinatal population for omega-3 fatty acids and DHA, as well as folate supplementation. Those that don't have great evidence are those listed here, so we typically don't recommend. The evidence with acupuncture is quite divided. I always say, well, it's not going to hurt anything if you feel like that's helpful for you, but we don't have great evidence to support that. I think what we do need to do is be really mindful about sleep hygiene and supporting sleep. It's not uncommon that I get a phone call through Periscope or see a patient in my office who's struggling with anxiety, and I ask about sleep, and they're like, well, I'm taking care of my baby, so I'm up, every 90 minutes all night long. And I'm thinking, I can't fix your anxiety until you're sleeping a little bit more than 90 minutes at a stretch. Like, we have to be able to think about that. That's particularly true in our patients who have an underlying psychiatric disorder and have struggled in their adult life prior to pregnancy with sleep deprivation worsening their symptoms. You've got 9 months to help make a plan. So let's figure out what that can be. Okay. So some of this makes really good sense. I oftentimes tell my parents that if you wouldn't let your kid do that, you shouldn't be doing it in terms of sleep hygiene, right? So no phones, no screens prior to bed. Don't utilize them when they get up with baby. I have moms all the time breastfeeding at 2 a.m. and they're on their phone scrolling. Oh my God, put it away. Like, put it away. Even just moving the phone or clock away from bedside to avoid clock watching, or just, the habit of checking it in the middle of the night. In a perfect world, our postpartum mamas who are struggling with mental health disorders would have a minimum of 4 hours of uninterrupted sleep. If they are struggling with depression or anxiety, we've got to be able to prioritize sleep. So that may mean that they're not exclusively breastfeeding via breast overnight. And that's okay. Early introduction of a bottle with express breast milk and or supplementation with formula to be able to support mom's mental health is really important. I talk about the concept of sleep shifts a lot. And so again, partner, support person, even if mom's 4-hour shift is in the middle of the afternoon, like, how can we get her 4 hours of uninterrupted sleep in a 24-hour period can be really powerful. If she's got a partner, can partner take baby, even if partner's working full-time or whatever that looks like. Can mom do 8 to midnight, and then, they tag team after that, and then mom's got the rest of the night if she's still on maternity leave. But kind of talking through whatever iterations that are, and that oftentimes then allows both partners to get better sleep versus both of them being up or only having one partner. I cannot stress the importance enough of preconception planning. So before I can kind of talk a little bit about medications, we know that 50% of pregnancies in the US are unplanned. That number is nearly 80% in women who have mental health conditions. So when you are engaging with people, asking them, do you plan to become pregnant in the next year? Do you want to become pregnant? Because that can really inform our next steps in conversation, either about um, conception planning with their medications, or can we kind of think about contraception? So kind of documenting that piece as well. And so, even when I speak to my psychiatry residents or faculty, I'm like, you need to be asking about birth control with every single visit with your reproductive age patients, and documenting this, because if they're actively planning on getting pregnant, you need to give them some guidance about what to do with their psychiatric medications. Because it really does become what I call a risk conversation. So yes, there may be risks of these medications to a fetus or pregnancy or neonate via lactation exposure. However, we also know, as we talked about, there's a huge risk of untreated mental health conditions. That's what we have to balance. It's not just about fetus exposure to this med. We have to think about, what does this mama look like when she has an untreated mental health condition? Unfortunately, what the data is doing is not comparing these apples to apples. They're comparing apples to oranges. And what I mean by that is, they have a pregnancy with baby that's exposed to a medication, and they're comparing that to a healthy mom who has no exposure, versus what they're not comparing to is a mom who has an untreated mental health condition, right? That is not ethical to do those studies. And so it does add an extra layer of how do we interpret these things, because we're comparing it against the general healthy population, not against what would actually happen if mom wasn't taking her meds. I hope that makes some sense. So what we do know about antidepressant use very broadly. So our SSRIs, Prozac, Paxil, Zoloft, Celexa, Lexapro, are our most commonly utilized medications in pregnancy for both treatment of depression and anxiety. That's true just in the general population as well. That being said, we've got really great safety data for 30 plus years with these medications in pregnancy. We know what to expect. We know how to counsel. We know how to guide patients with utilizing them. I think what's important for this group to know is that risks are not dose dependent for these medications. So if mom's on a high dose and she's needed a high dose to treat her anxiety disorder, there's no reason to drop that dose when she gets pregnant. A lot of my moms will say, well, I thought I'd have less of a risk to my baby. It actually hasn't panned out in the research. We also know that we've got good data with augmentation. Like if one medication's not enough, we're only getting partial remission, well, we're still exposing her to the med and to the symptoms. That's not great. Like, let's get rid of one of those factors. It's kind of how we approach this. And as I mentioned before, that last piece, we want to utilize the lowest effective dose. So the emphasis there is on effective. So risks are not dose dependent. And so ideally, I'd much rather have a patient on a higher dose of a medication and not have any residual psychiatric symptoms. Otherwise, in that risk, she's still being exposed to both. Let's just get her exposed to one. Things to think about with breastfeeding. I get questions all the time. Well, what about the transfer rate? And that's important, no doubt about it. But transfer rate isn't the only thing that we should think about when utilizing any medication with a breastfeeding or lactating patient. So the first thing that we do think about is this relative infant dose, also known as the transfer rate. So how much of the medication is being transferred into the breast milk that baby will then be exposed to. I will say that the vast majority of psychiatric medications fall well below what is recommended by the American Academy of Pediatrics as being deemed safe for use in pregnancy. The vast majority of them are well below that threshold. The other two things, though, that I think we oftentimes forget about is there an impact on breast milk supply, as well as impact on ability to parent. So that number two, impact on breast milk supply, a lot of psychiatric medications can either be drying, dry mouth, dry eyes, constipation. Well, if it's drying everything else, it's also going to dry breast milk. So we need to be thoughtful about that. And a lot of psychiatric medications work on dopamine, and the dopamine prolactin loop, it can then negatively or positively impact breast milk supply. So we need to be thoughtful about that piece. And then when I think about impact on ability to parent, primarily what I'm thinking about is sedation, right? If mom's really anxious or she's having insomnia, if I give her something to treat that, that's going to make her tired. Is that going to impact her ability to be able to care for that baby overnight or when that medication is in her system? So we need to be thoughtful about that piece as well. Even if it doesn't impact baby's level of sedation, is that impacting her sedation to be able to care for kiddo? Dr. Google's not my friend, will never be my friend. Dr. AI, even less of my friend these days. So that being said, like the evidence has changed so much over the years. I utilize, we can put in a clinical consultation to, AI or to Google, and it may pull up studies from 20 years ago that we now have newer things. So we really need to be mindful about how we are looking at our evidence because there's such a difference between kind of retrospective, kind of database reviews versus prospective studies, and that how many of those studies have changed over the years. And so we do need to educate our patients about this. Like, please just don't Google, call me if you've got questions, so that we can provide them with appropriate resources as well. And that's where programs like Periscope can come in. So these perinatal psychiatric access programs are really a real-time provider resource. So the Wisconsin's Maternal Mortality Review Committee and ACOG are now recommending, it's in their national guidelines, to utilize programs like Periscope to be able to get real-time consultation to support perinatal mood and anxiety disorders and substance use disorders for their patients. So what Periscope is an access program. Again, we are available at no cost to any healthcare provider or healthcare professional who is caring for perinatal patients. We do that by providing three main components. The first is real-time consultation. We also have community resource information and education. The whole point of programs like this is to have more access for perinatal mental health resources through capacity building of our frontline providers. So our obstetricians, our midwives, our family medicine docs, our NPs or PAs, anybody who is caring for these patients who hasn't gotten enough education or feels comfortable in caring for them can pick up the phone and contact our perinatal psychiatrists via our 1-800 number and be connected to those psychiatrists within 30 minutes. So we've got our 1-800 number, we've got an email, we're available Monday through Friday, 8 to 4. The vast majority of the questions that we do get tend to be about medication use in pregnancy or lactation. That being said, we can also help with diagnostic clarification, interpretation of a screening tool, or like the patient told me these things, do I need to be worried about it? So those are all kind of things that we can help support. And what we do is we tailor the consultation to the person who is calling. So I may have a very different conversation with a public health nurse than compared to an OBGYN or a psychiatry NP. And that's okay. Like, I'm happy to talk to anybody who I can support who is helping to care for a perinatal patient. What this looks like in real time, you call that 1-800 number, you're going to be connected to our triage coordinator. They're going to gather a little bit of information about who is calling. We're going to ensure that it's a healthcare provider, a health professional, as we do not talk directly to patients or families. A page is going to get pushed out to the covering psychiatrist, and that psychiatrist is going to return that provider's call. While we advertise that we're going to return that call within 30 minutes, most commonly it's within 6. Most commonly it's 2 minutes. It's just enough to kind of open the database, but on average it's about 6 minutes. So, and then we just have a case-based conversation. I oftentimes liken this to if we're walking down the hallway at the clinic and you see me and say, hey, Wickman, I just want to run this case by you. What are your thoughts? That whatever kind of guidance or direction or education that I give, ultimately it's up to that healthcare provider as to whether or not they want to implement that. So the care is staying with that patient. So what this can look like. So an OBGYN called us about a patient, G7, P6, 31 weeks pregnant. She had this history of depression and anxiety, but was not on any current medications. Prior to pregnancy, she was on alprazolam, so a benzodiazepine, and trazodone, which is a sleep medication. Her PHQ-9 score was quite high. Threshold is typically at 10 or 11, so she was quite in that severe range for depression. And We gave them a call back and we talked about different options. So initiating an antidepressant medication. We talked about the data for use of an SSRI in late pregnancy. We talked about other things that we could do to help support her sleep, magnesium or Unisom, or even a very low dose of a benzodiazepine. And we kind of talked about what appropriate utilization of that would look like during pregnancy. All in all, it was an 8-minute phone call. And so then the OBGYN could take those recommendations and take those considerations right back to their patient who is still in the office. We also keep a community resource database that is accessed through our triage coordinator. When we first started the Periscope project, I was aware that there's a lot of perinatal mental health resources in the Milwaukee area. That's where I practice, and keeping up with them was a pain in the ass, right? Just to know where everything was and who was still accepting new patients and did they change locations and et cetera, et cetera. So we do that. So we've got resources across the state, primarily, psychotherapy and AODA treatment centers, peer-to-peer support groups, other perinatal psychiatrists outside of the Milwaukee area. And what you do is you call our triage coordinator and say, hey, I'm looking for a therapist in the Green Bay area who accepts Medicaid. Do you got anything? What do you know about? So it sounds like there's some overlap with trying to do some of this community resource landscape as well. So we have also done a lot of that work too. So that's what we're able to provide. And again, all of these are specific to the perinatal population. And then lastly, we do a lot of education. So just like the last 45 minutes I've been talking to you, I give a lot of these kind of presentations across the state, really, to anybody who will listen to me. On our website, there is a lot of information as well. We have medication algorithms, we have modules. If you're not sick of listening to my voice yet, you can go listen to pre-recordings of other topics as well. And then we have quarterly live webinars that we push out on kind of subspecialty topics. From a community partner perspective, I would ask that you guys, certainly can consult us on how to discuss mental health with a client, or if you're doing screening tools and you're recognizing, oh, this is elevated. How do I talk to her about this? I get a lot of questions from our community partners about she screened positive for suicide. And I know you told me I had to ask some questions, but how do I do that? And can you help me understand, is this urgent, or is it an urgent or emergent referral, or is this not something I need to be worried about? So I get some of those questions too. Certainly you can ask our triage coordinator to send you some options for our from our community resource database. And then really to help spread the word about Periscope and share that with the client's healthcare provider, particularly if there's a concern about medication management. Because we know that really all of us can be the difference maker in a woman who is struggling with any mental health symptoms during the pregnancy or postpartum period. Any one of us can intervene and really change the course of a woman who is struggling. That's what I've got. I'm happy to take any questions that anybody has. I'll stop sharing so I can see. Okay.
Hi, I do have a question.
Sure.
My name is Denise Valdez. I work at Casa Alba Melanie, which is a Hispanic Resource Center in Green Bay.
Yeah.
And we primarily serve Hispanic and Latino, the community, the Hispanic and Latino community.
Mhm.
Most of the clients that I see are uninsured.
Yeah.
And the moms that I work with, they tend to come with a lot.
Yes.
It was either unplanned pregnancy, they have a partner, but the partner is not actively involved in the family planning or taking care of the
Mhm.
baby. Uh, they're in a new country, they feel alone, and all these layers.
Yeah.
And then you add, I had a baby, and then you add, I want to breastfeed, and my heart just goes out to them, because on a personal level, I remember when I had my baby, it was hard, and I
Mhm.
had all of the resources. I
Yeah.
can't imagine what it's like for them. So that being said, and you might have already answered this, but if you could just go through it, it would be really helpful. If a mother came to me that was in those shoes without insurance, could you walk me through what would be the best step on to get her some type of mental health support?
Yeah.
And if you provide Spanish speaking staff or translators.
Yep. So again, so Periscope is not, it's not a referral service for patients. You cannot refer patients to Periscope. Periscope is a healthcare provider support service. So we help provide education to the healthcare providers and help connect them with resources. But we do not do direct patient care. So you can't call up Periscope and say, hey, I want to refer a patient to you. We don't have anything for them to refer to. It's an education service for healthcare providers. That being said, in that case, I would make sure that wherever the patient had been seeking her obstetrical care, whether that's an FQHC or wherever they were getting some kind of care, to ensure that we can connect back with them to let them know about the concerns that you may have regarding their mental health. Sometimes that's most helpful by doing a screening tool or two to be able to have some objective evidence, to call that healthcare provider to say, hey, I'm working with this client. They are struggling with X, Y, and Z. I did a PHQ-9 and a GAD-7. Here's the scores for that, and hook them hopefully back in with care that direction, because if nothing else, they should be able to help at least support initially from at least a medication perspective. Wisconsin did just change postpartum legislation, so Medicaid will be expanding to a full year postpartum versus six weeks. So that would also help once that it gets implemented. That should also be covering mental health care as well. And we were part of the advocacy to do that because of patients like this then too. But you're right, like there's so many layers of how we can think about this. And then so I always kind of think back and try to take a step back and how are, if I think about all of the different things from like an a la carte menu, like how many different things can I grab? Can I grab a home visiting? Can I grab peer-to-peer support? What about medications, referral back to their OB or midwife care? What are other things that I can do? That may not just target mental health, but would provide them with support, childcare, respite services, all of those things. In our database, we do have some limited Spanish-speaking resources. They are limited, I'll be very frank, but we do have some within our database and some that are virtual. I don't know if it's Spanish-speaking, virtual, and Medicaid, but kind of what our database can help be able to look at.
Great, thank you.
Paul, I see your hand is up.
Yeah, thank you. I just wanted to say thank you for all the really great information regarding substance use during pregnancy and postpartum.
Yeah.
A lot of times there's nothing that's really talked about. I run a sober living for women and children in Green Bay, so I see a lot of that side of it. So I really appreciate the way you handled your presentation and everything. I'm actually thinking about possibly sharing it with the residents.
Right.
Just so they can see that we're working on stuff, or you're working on stuff, the wording and all the I call the no shame kind of theory.
Absolutely. And I think what's most heartbreaking to me in the work that I do with Maternal Mortality Review Committee is actually we get some access to the documentation and to the EMR, and it's heartbreaking to see how some of these patients have been referred to in their own medical record that they oftentimes have access to. Well, I would never want to go back to a healthcare professional that had labeled me in some kind of way. And so just being thoughtful about it. So yes, and thank you for the work that you're doing. If there's anything that I can do to help support, please don't hesitate to reach out.
Thank you. Yeah, I've seen it myself, the way people are treated, and it's just sad.
Yes, absolutely. There are different, I see. Katrina, are there specific resources or pathways for providers that work as community health workers So not a large healthcare system, but providers with smaller and more specific patient pops. What is your, I'm not understanding your question. I'm sorry. Katrina, about how to utilize or what do you mean? Did she drop off? It looks like she may have dropped off, Becky. Okay. If she's able to connect back with you, please let me know. I'm happy to answer. I'm not exactly sure unless somebody else in the room has a better idea of what the question was.
Yeah, I'm not sure exactly either.
Okay, that's okay. Yeah. Other questions? Otherwise, I'm going to be mindful of time. I know it's straight up noon. If there's other things that I can do to be helpful, please don't hesitate to reach out. Oh, well, that's very kind of you, Katie. Thank you. All right. Take care, everybody. Have a great rest of your afternoon. I appreciate the time.
Thanks, everyone. Thank you, Dr. McMahon.
Bye-bye.